Hi everyone, my name's Kathy Franklin. I'm a psychiatrist. I work with adolescents and adults with intellectual disability and also those on the autism spectrum. I am here today to talk about catatonia. This presentation is actually going to focus on how to detect and diagnose and really to understand how catatonia looks and how it presents in this population. I hope that this will be helpful. This presentation is targeted to be helpful for interested families and also health professionals to give you an introduction, but also a fairly clinical look at what catatonia is. I should also say that I work in Brisbane in Queensland in Australia. I am the director of the MARTA Intellectual Disability and Autism Service, which is a clinical service, and also the director of a small research centre, which is a University of Queensland research centre also in this area. So it's lovely to be with you. I've worked solely with this group of patients for about 18 years now. So I'm very familiar with this patient group and this topic. And I really hope that this will be helpful. I really find in clinical practice that catatonia is easily missed and it's treatable and preventable. So let's get on to it. Let's see if I can get this slide to move. I would like to start, because I'm speaking to you from Australia, and you might not be familiar with acknowledgement of country, but this is part of living in Australia. We acknowledge the traditional owners and their custodianship of the lands on which we meet. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. Before I begin, I would also like to acknowledge and thank all of my patients who've taught me a lot about this subject, and everyone else who has as well. There's a lot of professionals in this field who are very dedicated to working on the problem that catatonia causes. I also really want to thank the patient of mine who is starring in today's video and her family for coming to Brisbane and allowing me to video and to use her videos in today's presentation to help teach you about catatonia. And this is a photo of her here. There'll be other photos. Today I'm going to cover a little bit of the history. That's important to understand because you will encounter different attitudes and thoughts in the general population and the population of medical professionals around catatonia. Then I'll talk about how catatonia in particular presents in intellectual disability and autism. I'll move on to then explaining about what catatonia is and understanding the varied terms that we use to talk about it. I'll talk about how to detect and diagnose it and the diagnostic workup. I'm not talking about management as part of today's presentation. There will be enough to cover and for you to digest. So first of all, the history. It was actually back in the 1890s that catatonia was first recognised as an entity and described by Carl Baum. It was considered a part of schizophrenia until the 1980s. So this is important. A lot of people still think of catatonia as related to schizophrenia, but the field has moved on since then. It's also interesting. So way before the 1980s, Henry Rowland, a UK and English psychiatrist, described catatonic psychosis in a series of young people with Down syndrome. And in fact, this was the first case control study of Down syndrome regression disorder, which is what we call it now, where he compared 16 people who were affected with 41 unaffected. And that was published in the journals back then. It wasn't actually until 1994 that DSM-4 added the category of catatonia due to a general medical condition. So this was in response to the recognition that catatonia could be completely caused by a medical or an organic or a physical cause, so not a mental illness. And so that allowed that diagnosis. And DSM-4 also acknowledged through having an episode specifier that catatonia could be part of a mood disorder. So schizophrenia is associated with psychotic illnesses, but mood disorders are include depression and bipolar disorder, which we used to call manic depression. So catatonia can also occur with that. Then it wasn't until the 2000s that there were 2 published studies of catatonia in autism, and there have been quite a few since. In 2011, this was the next publication on Down syndrome and catatonia, where 2 cases were described. In 2013, so really quite recently, DSM-5, so the next one after DSM-4, still in the schizophrenia chapter, has a section on catatonia. And you can diagnose someone with catatonia associated with another mental disorder, and that includes autism spectrum disorder. That's not how the autistic community would like to consider autism spectrum disorder, but that's how DSM quotes it, categorizes it. Catatonia due to another medical condition, and that includes, for example, neurological conditions or metabolic conditions. Or unspecified catatonia, where the nature of the mental or medical disorder is unclear. So this is a summary slide just to explain really what I've just said. And really, what I've said is that there's a number of different conditions that can have catatonia as part of the presenting picture. And that's a really important concept. So catatonia doesn't mean one condition. It means it could be mental illness. It could be an organic, that's another word for a physical condition. It can be associated with autism and have no mental or physical illness, or what I call miscellaneous or not really understood. So that's an important concept, and that's part of the difficulty in categorizing catatonia. Before I move on, I just wanted to reflect and share with you a bit of the recent history of catatonia, because people who are non-medical and even non-psychiatric might think, well, everyone should know about this, it's in DSM. That's actually not the case. If some of the, doing a literature search, some of the articles on catatonia in general in recent times include titles such as Rediscovering Catatonia, the Biography of a Treatable Syndrome. So that's a kind of article telling the medical profession it's still there and treatable. Next one, catatonia is not schizophrenia and it's treatable. You're seeing a theme. There has been some talk about catatonia and the immune system, which is very interesting. Catatonia has been described associated with COVID. And lastly, there's articles about the gaps in understanding the features of catatonia among psychiatrists, psychiatry trainees, and medical students. So here's the thing. Catatonia can be right in front of you. It can be right in front of a health professional. It can be right in front of a doctor. It can be right in front of a psychiatrist, and they might not recognize what they're seeing. So keep listening. So I want to, before I get into actually talking about catatonia, I just want to talk about what we know about how it presents in intellectual disability and autism. And I thought about whether I should combine all of these or do a different autism and a different Down syndrome one. But, you know, some people have Down syndrome and autism. Some people have Phelan-McDermid syndrome and autism. So I thought I'll do it all together. So firstly, catatonia and how it presents in autism. There's enough literature, isn't this great, that there's been a systematic review published in 2021. They reviewed 12 studies and 7 of those were used in a meta-analysis, which had 969 individuals. So that tells us that's a good number. If these studies are done well, that this should be really helpful data to understand catatonia and autism. And what we know from combining those studies, the mean or average age of people with catatonia was around age 21, but there was quite a range. There are only 2 studies that included children and adolescents, so that's going to factor in. That's our health services are divided into children adults generally. So maybe that age is not so helpful. It is, however, reasonably young. In clinical practice, I would say it's more like mid to late teens would be the average age of onset. 70 to 100% were male, but again, the but there is that our currently still autism is said to be more common in males, but we're really not very good at picking it up in females. So I'm also a bit iffy about whether it's actually more common in males or not. We don't know that from this, I don't think. It is interesting to know that 10.4% of autistic individuals had catatonia. 10.4%, 1 in 10. If you are a health professional working with autistic people, 1 in 10 is a lot. And I think that tells us that we're missing a lot of catatonia. There was, interestingly, no difference in comorbidities. So people with catatonia weren't more likely to have schizophrenia or depression. And in fact, in my clinical practice, quite often autistic people who have catatonia have no other mental illness symptoms. So it's really just the catatonia, and that's not the case in when it occurs in Down syndrome or in Phelan-McDermid syndrome, for example. From this systematic review, we know several treatments were used: benzodiazepines, antipsychotics, and ECT. Those are fairly standard treatments for catatonia. The conclusions, of course, more studies are needed, and particularly studies into the response rates of different treatments. And I also just mentioned a case series, which is an interesting case to look at, but also the case series looked at a series of 20 autistic individuals who developed late regression in adolescence. And so the message here is late regression in adolescence, think about catatonia in an autistic person. I'll mention catatonia in Phelan-McDermid syndrome only briefly. Phelan-McDermid syndrome is also called 22q, well, it's caused by a deletion on 22q at 13. In this group, mental and Phelan-McDermid syndrome is really quite rare compared to autism and even rare compared to Down syndrome. The mental illness is relatively common in Phelan-McDermid syndrome, often mania with psychotic symptoms, also anxiety, but regression in catatonia occurs both in those who are autistic with Phelan-McDermid syndrome and those who have Phelan-McDermid syndrome and aren't autistic. Catatonia in Phelan-McDermid syndrome seems to respond to treatment for the mental illness, but IVIG also has been described to be used, and there are some articles. I just got some screenshots there about some of them. And lastly, catatonia and Down syndrome. There's been a really great growth in literature in this area, which helps all of us clinicians immensely, and also, of course, families. So that's so great to see. So there's a lot more than these 4 articles. This is just to illustrate some of the different things that have been published. So we're actually, the catatonia and regression in Down syndrome, although we've more recently looked at defining diagnostic features and reaching diagnostic consensus around diagnostic criteria. Actually, if we look back at that 1946 article, it describes it really beautifully. I do like that the older articles have that descriptive language. So I've summarized some of that here, and the photos are from the article as well. And that article back in 1946 described a cohort of young people with Down syndrome who had no previous history of behavioural problems. They had developed within normal limits for Down syndrome. Between age 11 and 14, they developed alarming and drastic changes so that families sought institutional care. So these were people who were living at home before, back in the 40s, who deteriorated such that they had to move into an institution. And the deterioration was rapid. There was problems with toileting. These aren't, I don't think, in order, but toileting. Speech, they became mute. There was a loss of interest and ability in activities. They became solitary, withdrawn, apathetic. destructive, and there was periodic excitement and agitation. Now, I should note, back then they moved into institution because there were institutions. That's not the case now. In clinical practice now, what really does happen in this patient group is that people go often from being really quite independent and not requiring much support to suddenly being very dependent for all of their ADLs and requiring one-on-one support. It's devastating, this condition. He also described additional catatonic features, and I'm going to explain what some of these are, but he described automatic obedience, waxy flexibility, echolalia and echopraxia, stereotypies, delayed or no response to pain, and a weight loss, which, and that lovely section of script, if you're looking at the slides later, do have a read. But the section of script really describes how the best example of indifference to the environment was the meal trolley coming and people with regression not caring, which if you know people with Down syndrome, that's pretty uncommon. Happens, but pretty uncommon. And in fact, the group of people with regression and catatonia had a 6.6 pound weight loss versus a 9 pound weight gain in the unaffected group. And the prognosis was bad. There was no treatment. And so there has been publication of current working definitions. And I've just highlighted some of the things there because the working definition doesn't spell out catatonia as an entity, for better or for worse. I think this was discussed, but in the context of catatonia not being well understood, it was felt more important to describe the various domains and areas. And really in Down syndrome, we see this, the big things are a deterioration in communication, the social withdrawal, and a loss of skills. Now, I do have to say the skills haven't actually been lost. They come back again when the person is doing better. In this group of people with Down syndrome who develop catatonia and as part of Down syndrome regression disorder, the mean age of onset is about 15 years. So again, that mid-teens time. There's no previous history in this group. The definition says no previous history of autism or epilepsy, but that doesn't mean that there's not generally. It's just trying to create a research definition, if that makes sense. There's also no hard neurological signs like you might expect to see in an autoimmune encephalitis, for example. Okay, so here's the tricky bit and the interesting bit. What is catatonia? The DSM doesn't actually say what catatonia is. DSM defines catatonia as saying the clinical picture is dominated by more than 3 of stupor, catalepsy, waxy flexibility, mutism, negativism, posturing, mannerism, stereotypies, agitation, grimacing, echolalia, and echopraxia. So having more than 3 of that is catatonia. Outside of the DSM definition, there's some other terms that are also associated with catatonia: Gegenhalten, automatic obedience, Mitgan, ambitendency, verbigeration, and perseveration. And I don't know about you, but after hearing that long list, even as a clinician who's read this stuff and figured out what that means, this is sort of how I feel. It all sounds very technical and very confusing. So I'm going to now tell you how I explain what catatonia is when I'm explaining it to a patient or their family. So the first thing I say is catatonia is a disorder of movement and control of movement and control of emotions as well. It can make it hard for your brain to tell your body what to do. If you remember nothing else from this presentation, remember this, because the important thing in that definition is that catatonia and the behaviours associated with it are not under conscious control. So they're not that sort of behaviour that's related to a trigger or a cause or something that someone's doing to get attention or some other function. Behaviours associated with catatonia are related to this, the fact that when someone's brain tells their body to do something, their body doesn't cooperate. So how does that look? It can make your body very slow or even completely stuck and unable to move at all. And we call that stupor. Your body might get stuck in unusual positions. When the person themselves is doing it, it's called posturing. When an examiner moves somebody and their arm stays like that, it's called catalepsy. Your body might move differently or feel stiff. That might be rigidity, waxy flexibility, or Gegenhalten, and I'll tell you a bit more about these to explain them a bit further on. You might have trouble speaking or stop speaking altogether, and we call that mutism. Your thoughts, speech, and body might get stuck on the same thing. When that's your thoughts and speech, it's called verbigeration, and that's when it's like a stuck record, same thing over and over, if any of you remember records. Perseveration is when you keep returning to the same topic. So someone tries to change the topic and you go back. When that is your body that's getting stuck on the same thing, it's called ambitendency. And that can look, for example, like if you're going to pick up a pen, you reach, but you don't pick it up, and you come back and you reach again, but you don't quite get there, and you come back and you reach again. So people might call this being stuck in loops, or it might look like repetitive behaviors. Your body might make unusual movements that you can't control. And there's some different types of these. Mannerisms are movements that mimic normal movements. So, for example, walking in a really odd way, maybe 1 foot on tippy toes, that would be called a manneristic gait. Or talking with a dull robot monotone, that would be manneristic speech. Stereotypies are other extra movements that aren't purposeful. And tics are a little bit similar to that, but how is they have more of that uncontrollable nature and can be more disruptive, really. You also might smile and your family might think you're happy, or your family might think you're hearing things, but actually that's often what we would call grimacing if it's an odd smile. You might also laugh or cry for no reason. And that can be hard sometimes to distinguish between whether it's that from catatonia or it's somebody responding, for example, to hallucinations. These last two things aren't part of the technical terms, but are important, and I always mention them. It can be hard to chew or swallow, so people can choke, they can hold food in their mouth, that's very common, and that's actually part of the catatonia. It can be hard to do your usual activities, and usually is actually. So people need more help with things like showering, dressing, toileting, and moving in general. So that's that list again. I've really just included this slide to relate back to the DSM criteria, particularly if you're a health professional watching this, and to share with you the definitions or explanations of those terms. So I won't read them out, but that just reminds us again about the DSM and how it diagnoses catatonia. So how do we do this in clinical practice? There must be some great tools to use, so let's find out. First of all, the interview questions. I've included these because catatonia is the sort of thing that if you don't ask about, you may not find out about. And it can be really easy. When I first saw my first patient with catatonia, I thought, oh, this is simple. They've just got depression, because I didn't ask these other questions about movement. And then when I went to treat their depression, it didn't get better. So it's important to ask. If you don't ask, you don't find out when it comes to catatonia. So these are the things I ask. Does the person ever get stuck in one position? And if so, how long for? So I'm asking about posturing. Do they get stuck in the middle of a movement? And that's ambitendency. Do they need help getting started with a movement, like feeding themselves with cutlery or taking a small step, taking any sorts of steps? Do they get stuck in loops of behavior? Do they have trouble crossing thresholds, for example, going through doorways or up and down stairs? Do they repeat other speech or movements, particularly if they never used to? And then I ask about whether they've noticed any decreased speech or communication, any increased slowness, and that can be a hard thing to define. So actually what the common parameters I ask is, how long does it take to eat breakfast now? And how long did it take before? Because quite often it might now take 2 or 3 hours to eat breakfast, and before it was 10, 15 minutes. And it's often easy for people to say how long they need to allow to get someone ready to leave the house. That tells me a bit about how slow they might be. And so that might have been before, it might have been half an hour, and now you have to get started 2 or 3 hours before. And families will commonly say, if I don't keep prompting, nothing happens. They could stand in the shower all day. They could stand in their bedroom all day. So that makes me think, oh, that sounds a bit like catatonia. I ask if there's any unusual movements, and particularly for clinicians listening, those movements can include eyes rolling back, and people can think that that's an ocular dystonia, and sometimes you can get dystonic movements as part of catatonia, but importantly, they don't respond to benztropine or the treatments that we would give for ocular dystonias or oculogeric sort of crises. So it's important to know that can be part of catatonia. And I've had a few patients with that where it's not responded to benztropine, but has responded to lorazepam. Have there been any repetitive frequent movements or odd ways of doing usual things? And this often gets a response as well, like walking backwards, stepping sideways, walking along walls sideways, things like that. Have there been any unusual facial expressions like grimacing, any abnormal staring? So I don't mean just sitting there, but I mean sort of staring into space and not blinking. Sometimes people can not blink for a very long time, and then you have to worry about the well-being of their eyes. They can get very dry eyes. Sometimes people change handedness. So they go from being left-handed to right-handed with catatonia. It's a total mystery. It's a fascinating condition. There may also be periods of rushing around and agitation without any obvious trigger. And so when this occurs in catatonia, it generally looks like sitting there fine, doing nothing, suddenly leaps up, bangs into the wall, sprints through the house, and it's quite marked generally. Okay, so a lot of questions there. I've just realized I just want to go back to this DSM list, because I also want to say some of these things, particularly mannerisms, stereotypies, echolalia, echopraxia, those things can be part of autism. So it is important, if you're looking at someone who's autistic, to establish how many of these sorts of things they had in the past. It's actually usually not too difficult to differentiate those things. Just thought I'd mention that quickly. Sorry to flick through those slides. Okay, diagnostic aids. Best diagnostic aid, home videos. What home videos? I ask for particularly, well, any home videos, but a video of eating, a video of them getting stuck, a video of them walking, a video of them getting in the car, and then a video of anything odd. And those are the best diagnostic things to see, really. There are various catatonia rating scales. The Bush-Francis catatonia rating scale is, I think, probably the most researched and reported and validated, and there's a picture of that here on the screen. Further on in there are some excellent resources that have just been put on the net by the University of Rochester just this year, and I will give you a link to that in the comments. Excellent. If you're a clinician interested in this area, definitely have a look at that. Dr. Judith Miles is I want to say, medical geneticist in the United States who has developed, along with colleagues, a Catatonia impact scale, but it's not published and not validated. But I do really like the questions and the domains. It is long, but it really does. It's designed for family and carers to fill it out and to be able to monitor response to treatment. So it is really long, but I really like. I think it's quite sensitive and probably specific. There are no intellectual disability or autism specific rating scales that reliably assess for catatonia, none. The MOS-PAS suite, the MOS-PAS structured interview does have a section on catatonia, but to be honest, it only really considers catatonia in the presence of psychotic symptoms, and I don't find it very helpful or reliable in this area. So there's really nothing yet. People are working on it. So I'm looking forward to that. Okay, so now we're going to get on to a case example. First, I'm just going to show you a little snippet of a video of this patient with Down syndrome who was 19. And this video is before she got unwell. And I want you to look at how quick she's moving, her facial expression, her speech, and just remember that because we'll move on to some videos of when she has signs of catatonia. I hope you could hear that. You're so charming. She is totally charming. Now, I just wanted to share, so well, I'm not going to harp on about how hard it is to find help, but I've left this in to say and to warn you that it can be really hard to find medical professionals who can detect catatonia or understand that it's not just part of the person's disability. And so this is when she presented to a hospital with, just listen to what she presented with, a week, symptoms of severe decline in motor function and a deterioration in activities of daily living, unable to walk or talk, hunched, drooling, coughing, choking episode, only saying yes or no. History of Down syndrome. What's the diagnosis? Reactive mood changes. Now, to be fair, I'm so pleased that she was admitted and the hospital did screening blood tests and they were very thorough with doing a CT scan of her head to exclude moya disease and a scan of her brain as well. And they checked her spine in those scans. So I am super impressed that they did those things. So I'm only sad that that then they said reactive mood changes. But luckily her mum could Google and could find help. So here in these pictures, we can see that and the history too was that, see how her chin is stuck down on her chest. She didn't lift her chin from her chest. She walked like that, and it was very difficult to get her to lift her chin. She also showed very little verbal communication. You can see how, actually, look at her arms. They're stuck up in the air. That would be posturing. So that's spontaneous, active maintenance of a posture. So the chin on the chest and the elbows and the hands in midair. She actually, her mum has figured out that instead of pointing normally, she puts her hand up to try and point. So we'll see that in this video. Can you move your head up at all? Can you look up? Look at mum.
Can you, where's Mum? Can you look at Mum?
That's her pointing at Mum. Okay. Look. Now, catalepsy. We talked about posturing, how she's holding her arms in an abnormal position. Catalepsy, we'll see in this video, is when I'm attempting to position her arms and getting her to put them down again.
Put it down if you want.
You can see her trying. See her moving the rest of her body, trying to get her arm to go down.
Yeah.
And you see this in people with catatonia.
Feel better help you? If I help you.
You see people with catatonia will develop all sorts of movements to try and get their body to do the right thing. Sometimes it looks strange, but I'm really quite sure that's what they're doing some of the time. Gegenhalten is one of those names that's not in the DSM definition, but it's about muscle resistance proportional to the force applied. So rigidity is just when it's quite hard to move it at all. Gegenhalten is when it is a slight difference, and waxy flexibility is different again. Just see if I can show you that. The mouse has disappeared. Oh, here it is. There we go. Really very hard to push that leg down. Very rigid. But she did allow me to move it. At first, she didn't. Whereas her other leg, much easier. Can you see there? Much easier to move. Still some tightness, but much easier to move. If I go back again, you can see, yeah. See how hard it is to move that. So in this video, I just put a pen on her lap and asked her to pick it up, which actually was quite stressful for her. So just watch. And so ambitendency is often, really, with catatonia, you see a lot of difficulty initiating a motor sequence. Once someone gets going, they're usually okay, but the getting going and sometimes the stopping can also be difficult. So you might see them stepping backwards and forwards in a doorway, or reaching out to get something, for example. For me. So this is her trying to pick up the pen. And so she starts by trying to put it on a flat surface. But she can't get those arms down. She's trying, see?
Sure. See if you can pick the pen up.
And the arms go back, so that technically that could be considered negativism when you're doing the opposite of what someone asks you, but I really just think she was just trying super hard. For me. So what happened with her is the first day she came, this is the real world. The first day she came, and I wasn't really set up to do videos. I just had a phone, and but she had such excellent signs of catatonia, and she was coming back the next day. So the next day I had a tripod and someone to help me video, because her mum took the videos on the first day, and I was all set up. But she actually had some lorazepam half an hour before. So I tell you that because she's heaps better in this video. Now, that doesn't mean she was cured, but just these catatonic signs really improve. And that was her first dose of lorazepam, and it was a small dose, I think 1/2 or 1 milligram of lorazepam. You can see she's smiling and looking at me even before I press play.
Can I have a look at your hands?
So I'm looking for a palmar reflex there, which is not there, which is normal. She's still not talking, but there's no rigidity.
You couldn't help me yesterday, but today you help me. So now we're going to do that. Put it up. Can you let it go back down? So good. It's really good.
So that's how it should look. And then I'll just show you how her legs looked the next day. That leg was pretty good the day before.
Is that funny? Okay.
Little bit of waxy flexibility on the left still.
Good job.
But she was pretty happy with how she was doing. And so lastly for this section, what's it feel like to be catatonic? People who are catatonic often show very little emotion. They look very bland. Is that how it really feels? We don't have any studies from people with intellectual disability or autistic people to know, but people from the general population have been studied, and there's a couple of papers, and they tell us that they had intense emotional states that couldn't be controlled. So feelings of deep sadness, even when they didn't have depression, fear and anxiety, fear that they were dead or dying, feeling very lonely or lost, and some felt angry or irritable, trapped or withdrawn. And so what that tells me is that there's part of that sounds like a reaction to being trapped in a body that's not working and doing the wrong stuff. But also I suspect that there is also a lack of control around emotions and things as well. The same that we see in movements, and we see that laughing and crying for no reason. I think the person is probably also feeling happy and sad for no reason at those times too. I do have some patients who have told me, and this patient, the last sentences she said before she came, which was a few weeks before she came to see me, was, "What is happening to me and what do the doctors say?" And I've had recently seen an autistic patient who's said, "This is awful. It makes them feel like dying. They have lost so much of their life that they had because it takes so long to get help." So it's not much fun. Diagnostic workup. Now, I've tried to sort of simplify this, particularly to relate to clinicians, particularly to relate to probably psychiatrists. So in psychiatry, we and in intellectual and developmental disability, when someone turns up with a deterioration, there are some baseline tests that we do, and those are blood tests, a full blood count, markers for inflammation, thyroid function. We think about iron studies, B12, folate. We think about an abdominal x-ray looking for constipation, and we think about what their teeth are looking like, because people often can't tell us if they've got dental problems or pain from other causes. If it's someone who presents with catatonia and they have Down syndrome, there's this extra list of tests, thyroid antibodies, celiac serology, other autoimmune markers, and also thinking about an MRI of their spine, an angiography of their head and neck, because moyamoya disease is rare but still more common in Down syndrome. That's an abnormality of the vessels in the brain, and people can have mini strokes initially that can be hard to detect because they get better again, but those mini strokes can turn into a big stroke. So it is something that is, we have people presenting with what looks like Down syndrome regression disorder, and it can turn out to be moyamoya. So that's something that is important to think about and ask about in the history. And hearing and vision is actually really important in everyone with intellectual and developmental disability. And then there's more tests that we would think about in all patients, and that would be in blood tests and autoimmune encephalitis screen, because this could be a presentation of autoimmune encephalitis. Catatonia can be one of the presenting features. A brain MRI with and without contrast, an EEG, and a lumbar puncture, including oligoclonal bands, IgG index, autoimmune encephalitis screen, and neopterin. And just also think about that swallow, because we don't want people choking or aspirating. Now, I also have to say, for families, doctors often, not always, but often like to decide whether it's worth doing some tests and not doing some other tests. So the main thing that I do is try to explain the reasons behind these things. And the main reason for the more invasive things like a lumbar puncture is because this could be autoimmune encephalitis. The reason behind the angiography in Down syndrome is because it could be strokes and things. So there are reasons for these things. It's not just everything we can think of. And so really my closing thoughts are actually really a lot about remember that catatonia exists. And I know if you're a family member and you've got someone with catatonia, then I know you don't need to remember that because you see it all the time. But if you're a health professional, please remember that catatonia exists, particularly in intellectual disability, particularly in Down syndrome and Phelan-McDermid syndrome, and in those on the autistic spectrum. 10%, remember. What's the red flags? An obvious and marked deterioration in movement and speech, and an obvious and marked withdrawal of them into themselves and deterioration in self-cares. Really, the big question for psychiatrists is asking about their movement and their speech, because that's not part of your usual questions. So do ask. And I will do another presentation on treatment, but when we're talking about catatonia, the treatment is as per the general population treatment for catatonia. The exceptions are Down syndrome regression disorder and Phelan-McDermid. IVIG is being used as a treatment in some centres and being actively investigated as an option. So that's another thing to look into. I just wanted to then share these resources with you. The University, if you Google University of Rochester and Bush Francis, you will come up with these amazing resources. And if you're a clinician, they've even got like test videos so you can score things and figure out if you're picking up the right things. They've got videos to show you all of the features. It's a brilliant resource. Do have a look. I think that there is some information on Down syndrome regression but I couldn't find a web link to put in the presentation. I did find information for autistic adults as very general information on autism and catatonia. I've put some selected references for non-medical people, non-health professionals. Open access means it's free to download, and a number of these articles are. You can see I've put open access in brackets if they're free to download. Same with these other resources. So thank you very much. I hope that this has helped educate you around how catatonia looks so that you can feel more confident about what you're seeing when you're seeing a patient. And if you're a family member, I hope it's helped explain a little bit about what some of these features with strange names all mean. Okay, thanks very much.